Hello everyone. So in the previous section we saw the conventions and today we are going to cover the general coding guidelines. So in the section 1 under the heading B we are going to cover the general coding guidelines. There are 19. So we'll take one by one. So the guideline which are given in your book, I tried to simplify by putting them into the points. So the first point is use always both the alphabetical index and tabular list when selecting a diagnosis code. Start in the alphabetical index, verify the tabular list, follow the instructional note, and watch for the dash. If you can see here, there is a dash. At the end of the alphabetical index entry means there are additional characters which are needed to form a complete code. Even without a dash, the tabular list must be checked to ensure the completeness. The correct sign also indicates that the additional character to the code. So if you can see in the alphabetical index in front of every code, so you will see this correct sign. That means there are additional characters. Point number 2, the level of detail coding. Diagnosis code must be reported with maximum number of the character to reflect the highest level of detail in the medical record. 3-character code represent the general categories and should be only used when no further subdivision exists. A code is considered invalid if not coded to its full required length, including the 7-character when applicable. So let us take this example that in the alphabetical index, you will see the code like T26, T20.66, and this code talks about the second degree. Now, if you are in a hurry and if you just pick up this code and write, it is an invalid code. Because in the tabular list, if I go, it talks about corrosion of the second degree of the forehead and cheek, and this particular code requires a 7-character. So we need to add the 7-character, then only this will be a valid code. Guideline number 3, code or codes from A00.0 through Z99.8. The appropriate code or codes from this range must be used to identify the diagnosis, symptoms, condition, problems, complaints, or other reason to the encounter or the visit. Let us look at the point 4, that is sign and symptoms. Sign and symptom codes are used when definitive diagnosis has not been confirmed by the provider. Sign and symptom codes are acceptable for reporting the undiagnosed condition based on the patient's symptoms. You will find these codes in chapter 18 that begins with the letter R in the ICD-10 classification. So what does it mean? A patient comes to the clinic complaining of the abdominal pain and nausea. But after examining and testing, no specific diagnosis is made. So in this case, I can code the sign and symptom because I do not have the confirmed diagnosis. So I'll be coding the unspecific abdominal pain and nausea. Point number 5, conditions that are an integral part of the disease process. Sign and symptoms that are associated routinely with the disease process should not be assigned as additional code unless otherwise instructed by the classification. So what does it mean? The fever should not be coded separately when associated with influenza, as it is common symptom of the disease. Or chest pain should not be coded in addition to the acute myocardial infarction, since it is routinely part of the condition. So we will not code the sign and symptom if they are the integral part of that disease. Point number 6, pay attention, the conditions that are not an integral part of the disease process. Additional sign and symptom that may not be associated routinely with the disease process should be coded when present. So for example, fever occurring in malignant neoplasm. We need to code that separately as it is not routinely part of the disease process. Or cough in a patient with a gastroesophageal reflux, which is normally called as a GERD, should be coded in addition since it is not an integral symptom of the GERD. Now the point number 7, multiple coding for a single condition. Some of these points we have already learned in conventions. So some conditions require more than one code to fully describe the disease, including cause and manifestation. Use additional code notes indicate that second code should be added to identify details like infectious organism. Code first note means the underlying condition should be listed before the manifestation or related condition. So we have seen this in the previous uh, conventions also. Point number 8, acute and chronic condition. If the same condition is described as both acute and chronic and separate subentry exist in the alphabetical index at the same indentation level, code both and sequence the acute code first. So for example, acute and chronic tonsillitis. Now in this case, if you have seen, we have the two sub entries, this is the acute and this is chronic. So in this case, I will code both because that's what the doctor diagnosis is, and I will code acute first followed by chronic uh, because that's a guideline. Point number 9, combination code. A combination code is a single code that identifies two diagnoses, or a diagnosis with a manifestation or diagnosis with complication. Use only the combination code when it fully describes all documented conditions. Assign an additional code only if the combination code lacks necessary specificity. So for example, the type 2 diabetes patient with a ketoacidosis without coma. Now in this case, this is the disease and this is, you can say, manifestation or the complication. So I'm going to check whether this is denoted by one code. And if we see that E11.10 type 2 diabetes mellitus with ketoacidosis without coma, and it is explaining everything, so there is no need to write additional code, and this one code is called as a combination code. Let us understand the point 10, sequela, which is also called as a late effect, very important point. A sequela refers to a residual condition or the late effect that remains after the acute phase of an illness or injury has ended. There is no time limit for using the sequela code. It may appear shortly after or years later. Coding sequela usually requires two codes. The residual condition or the current problem or the effect is coded first. The sequela, which is the cause code, is coded second to show the original condition or the injury. So this is very important, and I'm going to show you the example in the next slide. So let us take one example to understand the sequela. A patient is seen for scarring and stiffness of the left eye resulting from the burn that occurred several years ago. Now, whenever you have the sequela question, the best thing is you ask, why did the patient come today? The patient came because of the scarring and stiffness of the left thigh. So that will be your first code. So L90.5, that is a scar condition, and fibrosis of the skin, that is a residual condition, which is coded first by the code, and because that's a current problem. And then the second code will be T24.012S. Now this is the unspecified degree burn of the right thigh, sequela, and because S at the end of the burn code indicate that it is a sequela and not a active injury. So how will I find? I will go to the burn of the unspecified degree, because I don't have the degree of the burn of the left eye. So T24.012, it requires a 7 character, and in this case it is a character S sequela, because this is the original injury, and this original injury has caused the scarring and stiffness. So the sequela of this injury is this. Okay, remember that. And this is how we will write it. This code first, this code second. So let us take the guideline 11, impending or threatened condition. When a condition is described as impending or threatened, coding depends on whether the condition actually occurred or did not occur. If the condition did occur, code it as a confirmed diagnosis. If the condition did not occur, check the alphabetical index for the subentries under the condition impending or threatened. If there is no specific subterm, code only the underlying condition and not the impending or threatened condition. So let us take two examples for you to understand this. A patient is admitted with a threatened abortion. That means the pregnancy, but the threatened abortion is the pregnancy continued and abortion did not occur. So now in this case, what will I do is I will check whether the alphabetical index has a subentry for the threatened abortion. And there is a subentry O20.0. Threatened abortion is listed as a specific subterm in the alphabetical index and I will code it. Now we'll take one more example. The patient is admitted with a chest pain and probably impending myocardial infarction, but the infarction does not occur. The alphabetical index has no subentry for the impending myocardial infarction. So therefore, what I will do is I will code the underlying condition because we have this guideline that when there is no specific symptom, you can code the underlying condition. So in this case, the underlying condition is a chest pain, that is a angina. So instead of coding impending myocardial infarction, I will code unstable angina. Point 12. Reporting the same diagnosis code more than once. Each unique ICD-10-CM diagnosis code can be reported only once per encounter, even if the condition affects both the sides or multiple sides, unless separate laterality codes exist. If the laterality specific codes are available for the right, left or bilateral, use them. If not, report the single code once to represent the condition. So let us take example. A patient is diagnosed with osteoarthritis of both the knees. Now in this case, I am going to write the code M17.0 because the code language uses the word bilateral primary osteoarthritis of the knee. So because the code language use the word bilateral, I will use this code only once. Remember that. Point number 13, laterality. Some ICD-10-CM codes specify the right, left or bilateral involvement. If no bilateral code exists, use a separate code for the right and the left side. If the side is unspecified, use the unspecified code, but only when documentation cannot be clarified. For separate encounter, use the bilateral code for the first encounter and a unilateral code for the second if the condition no longer exists on the first side. Now, remember in ICD-10-CM we have the code for the right, upper, left, bilateral and unspecified. So, if the patient is diagnosed with a carpal tunnel syndrome, side not documented in the medical record, then what code I will write? I will write the code I will write the code G56.00. Why will I write the code? Because it is an unspecified upper limb. Okay, and we will write that code. Point number 14, documentation of complication of care. This is a new point which they have added. Coding for the complication of care depends entirely on the provider's documentation that links the condition directly to the medical procedure, surgery or treatment. A complication code should be assigned only when there is a cause and effect relationship between the procedure and the resulting condition and the condition is clinically significant, that is, it requires a treatment. It is not required that the provider use the exact word complication. If the documentation clearly shows that the procedure or the treatment cause, or contribute to the condition, it can be coded as a complication. However, not every condition that happens after the surgery or care is automatically a complication. There must be clinical evidence and documentation of that relationship. If the documentation is unclear, coder must query the provider for the clarification before assigning the complication code. So remember that whenever there is a complication happen, find out why this complication has happened, whether it is related to the surgery, whether uh, there is no relation, and whether it is clinically significant, which requires a treatment or monitoring. So let us take one example of complication of care. Patient undergoes a hip replacement surgery. 2 days after the surgery, the patient develops a post-operative wound infection at the surgical site. The provider documents that a post-operative wound infection due to hip replacement surgery. Now in this case, the first code will be this, that is other post-procedural infection, initial encounter, and second code is presence of the right artificial hip joint. Now the documentation shows a clear cause and effect relationship between the surgery and the infection. The infection is clinically significant, requiring a treatment. The provider does not need to use the word complication because the relationship implies in the note. So he did not, so if you read this sentence, he did not use the word post-operative complication. He said post-operative wound infection. So he doesn't have to use the word complication, but this statement is clear for you to understand that there is a cause and effect relationship between the surgery and this wound infection, and therefore is coded as a complication of care. So let us understand point 15, syndromes. When coding syndromes, always start by checking the alphabetical index for specific coding guidance. If the syndrome has a unique code listed in the alphabetical index, use that code. If no specific code is provided, assign the code for the individual manifestation of the syndromes. Many a time there won't be specific code provided for the syndrome. That time we will use the all manifestations of the syndrome written in the documentations. Additional code may also be used for the manifestation not routinely associated with the syndrome. So let us take one example for us to understand all these points. A patient is diagnosed with a Down syndrome and has a congenital heart defect. So I will go to the alphabetical index to find out whether there is a specific code for the syndrome. Now in the alphabetical index, there is a specific code Down syndrome unspecific. So I'll pick up that code. Now why I'm writing atrioventricular septal defect? Because the congenital heart defect is not an integral part of the syndrome. And we have this guideline that manifestation which are not routinely associated with the syndrome, we need to code them additionally. So we are coding this additionally. Now, the point number 17, that is borderline diagnosis. When a provider documents a borderline diagnosis, it is generally coded as a confirmed condition, unless the ICD-10-CM specifically provide a borderline entry. If such a specific borderline code exists, that code should be used. Because the borderline conditions are not considered uncertain diagnosis, this rule applies to both inpatient and outpatient setting. If the documentation is unclear, the coder should query the provider for clarification. This is pretty much same like impending and threaten. So if we have the entry for the borderline diagnosis, we must write that. A 25-year-old patient is evaluated by the psychiatrist who documents borderline personality disorder. So I'm going to look whether I have the code specifically for the borderline personality disorder. I do have the code, so I'm going to write that code, borderline personality disorder, and it is coded directly as documented. So we have the borderline personality disorder F60.3. Okay. Guideline 18, use of sign, symptom and unspecified code. Sign symptom codes are used when only symptoms are known but no confirmed diagnosis. This we have seen earlier also. Unspecified specified codes are used when diagnosis is known but details such as type, site, or cause are not available in the documentation. Each encounter should be coded to the highest level of certainty known at that time. Never assume or assign a more specific code not supported by the documentation. Coders and provider must work together to ensure documentation is accurate and complete. But it is also appropriate to use unspecified code when clinical information is incomplete. So let us understand this. A patient present with a chest pain and after evaluation, no definitive cause is identified. So in this case, I can use the symptom because I do not have the confirmed diagnosis, and I will use the code R07.9 chest pain unspecified. And here the second example is provider diagnosed pneumonia, but the specific organism is not documented. So it is perfectly right to code the unspecified code here because we have the condition, but there is no specific information about the bacteria or viral. So I'll be using this particular code. Point number 19, use of external cause of morbidity codes. External causes of morbidity codes are used to describe how an injury or health condition occurred, including the cause, intent, place, activity, and status of the person. These codes are supplemental. They are never listed as the principal diagnosis. The injury or a condition code must always be sequenced first, followed by the appropriate external cause code. External cause codes are assigned for each encounter related to injury, regardless of healthcare setting. There are they are not used when the patient condition is unrelated to an injury, poisoning, or adverse effect. So, a patient sustained a second degree burn on the right forearm after accidentally spilling hot soup while eating at home. So, in this case, we will write the first code uh, that is about the second degree burn. The second code will be contact with hot food. The third code will be unspecific place in the resident as the place of occurrence, and then the activity preparing or eating food, and unspecific external cause status. So this is how we write the external cause code. We have a separate alphabetical index for that, which comes after the table of drugs and chemicals. So this is how we have learned the general guideline, and now the next is chapter specific guideline that will learn it.